Well, welcome everyone. My name is Dr. Stephen Cozza. I am a professor of psychiatry and pediatrics at the Uniformed Services University, where I serve as associate director for the Center for the Study of Traumatic Stress. It's a pleasure to be here today, and I will be speaking about how we as clinicians need to be staying alert to suicide risk in teens, young adults, and specifically the athlete population. And what I'd like to do is to talk today a little bit about terminology, describe some of the changing rates of suicide in the US that are relevant to young people, discuss the most common methods of suicide in that population, describe risk and protective factors for suicide risk, focus specifically on athletes as a unique population, and then discuss screening, assessment, and interventions that are appropriate in the primary care and specialty care settings. Next slide, please. I'd like to start just with my disclaimer that the opinions and assertions that I describe here in this presentation are my own and do not reflect the official policy or position of either Uniformed Services University or of the Department of Defense. Next slide, please. So I'd like to start with a clinical case presentation. Matt is a 17-year-old high school senior who presents to your clinic 1 week after surgical repair of a left-hand ligament tear. An avid soccer player and an aspiring NCAA athlete, Matt is out for the season after having missed the 2020 season due to COVID-19. Formerly an A student, Matt's mother describes him as unmotivated, irritable, and isolative. I'm really worried about him, she says. All he seems to want to do is play video games on his computer. So our first question is, are we concerned about Matt? Well, of course we are. He's had significant losses and disappointments. He's evidencing changes in his mood, changes in functioning and social isolation. And he could have a mood disorder, depression, adjustment disorder, or another kind of mental health problem that's contributing. But what we also want to think about here is the importance of screening him for potential risk of self-harm, screening him for suicide. Screening for suicide in populations where there is risk is extremely important. And what's also important is understanding how to do that, what clinicians should say, what they should ask, and how they should address a problem like this. So that's what we're going to be discussing today. We also want to make sure that clinicians are comfortable in assessing for suicide. Next slide. So to think some about terminology, suicide behaviors refer to a range of self-harm behaviors, and it's important to distinguish them. And language is very important because of stigma associated with suicide. So suicide is the act of intentionally ending one's own life. It is neither a crime nor a sin. Therefore, language such as committed suicide, although once was common, is really highly stigmatizing and not appropriate. People commit crimes, commit murder, but they don't commit suicide. When we think about suicide, we really should be talking about suicide or completed suicide. Similarly, terms like successful suicide are also inappropriate because they're oxymoronic in the sense that there is nothing successful about completing a suicide. And therefore, it's better to keep the terminology simple. Similarly, there are other terms, suicidal ideation, which refers to thoughts of engaging in behavior intended to end one's life, suicide plan, or the formulation of a specific method through which one intends to die, or suicide attempt, which is engagement in potentially self-injurious behavior in which there is an intent to die. Similar to language like unsuccessful or failed suicide, an unsuccessful suicide attempt is similarly inappropriate. There's nothing unsuccessful about not killing yourself, so we need to be thinking about suicide attempt or past suicide attempt. That's the appropriate language. Although non-suicidal self-injury can occur in populations that are at risk for mental disorders or potential suicide attempts or completions, self-injury in itself is not considered suicidal behavior. It's injury in which a person has no intent to die, such as self-cutting. Next slide, please. So why are we concerned about suicide in young people? Well, the data are pretty clear. These graphs show rates of suicide since 2000 through 2017 for males and females, males on the left, females on the right, ages 15 through 19 in the United States. Important to note that males consistently have rates that are 4 to 5 times higher than females as it relates to suicide, risk of completed suicides in the population. And we can also see the changing rates of suicide over time. So, we saw a general flattening or decreasing trend in suicide rates for males up until 2007, with increasing rates beginning in 2007 and annual percentage increases in rates of up to 14% since 2015. Similarly, with females, we've seen elevated rates in teenagers from 15 to 19. Next slide, please. Now, these are the same statistics for males and females, the ages of 20 to 24, so young adult populations. And again, in males, we've seen slow but steady increase in rates, running from 20 per 100,000, and now over the past 5 years approaching 30 per 100,000 suicides in males in the United States, ages 20 to 24. For females, we've seen a consistent increase in rates, although they're lower. These trends, anywhere we look for young people, whether they're teenagers or young adults, have increased in the United States. Next slide, please. What this has resulted in is increases in suicides more broadly, and also for the year of 2018, in reporting CDC data, we see that suicide became the second leading cause of death for young people ages 15 to 24, with over 6,000 suicides identified during that year. What this doesn't include are potential completed suicides that were not identified as suicides, such as accidental overdoses or single car accidents. It's also important to know that there are differences in rates across the population. We see higher rates of suicide in American Indians and Alaskan Natives, although we've traditionally seen lower rates of suicide in African Americans. Those rates are also going up for young African Americans, which is of concern. And a recent study found actually in the age group of 5 to 12 that the suicide rates for Black children were higher than white children, which was an unexpected finding. Risk factors for Black youth suicide are likely to differ and include experiences with racism, discrimination, as well as disparities in mental health availability, exposure to poverty, trauma, violence, and death in communities. Next slide. So this is a data that report on the method of suicide in this same age group from 15 to 24 in the United States from 2001 to 2019. The 3 most common causes of suicide in that age group are death by firearm, suffocation, and poisoning, in that order, with more than 50% of suicide deaths in that age group associated with firearm suicides. This has resulted in over 2 million lost years of life in that population during that same period of time. In the lower right-hand corner, you can see the changing rates of suicide per 100,000 based upon method used. So there's been a generally low and flat curve for suicide associated with poisoning, and increases in using the methods of suffocation and firearms. Specifically with firearms, since 2007, we've seen escalating rates through 2018, with maybe some decrease in 2019. In the lower left-hand corner, you see differences in rates based upon sex of the young person. So in the bottom bar graph, male rates of male suicide associated with firearm use is over 9 per 100,000 in comparison to females, which is much lower. The importance of this for clinicians is recognizing the means by which young people do complete suicides, and the importance of being aware of how to limit access to lethal means within the community that you see or that you treat. Next slide, please. So in considering risk factors, it's important for clinicians to have an understanding of the risk factors that contribute to youth suicide. Those include recent or serious loss, the presence of a psychiatric disorder, specifically depression or trauma-related, a history of childhood trauma or child maltreatment increases risk for suicide, prior suicide attempt, substance use disorder. Those who are struggling with sexual orientation, their elevated risk of suicide in the LGBTQ population, family history of suicide, lack of social support and bullying. I do want to comment on this access to lethal means. It's extremely important for clinicians to be aware. So in several studies that have looked at firearm storage practices in the United States, both in civilian and military communities, we found that in families that own firearms and have children under the age of 18, 20% of those households maintain firearms loaded and unlocked, a highly unsafe way to be storing firearms, and certainly are accessible to teens and young people. And if they have other risk factors associated with suicide, can put them at much greater risk because of the access to lethal means. Next slide. But there are also a number of protective factors for youth suicide that clinicians need to be aware of. For example, good problem-solving skills, strong connections to other young people, or whether there be peers, friends, or adults, parents, coaches, teachers, decreases risk of suicide. Restricted access to lethal means, as well as access to clinical intervention. Next slide. Additionally, some recent contributions to youth suicide risk include reports related to risk associated with the COVID-19 pandemic, specifically decreased psychological well-being among young people, whether it has to do with depression, anxiety, or sleep disorders, decreased social connectedness, loss of activities, opportunities, and aspirations, as was described in our clinical case of Matt, where young people who were looking forward to or were planning on certain events or activities or future life course had those canceled due to the COVID-19 pandemic. In addition, the opioid crisis has added risk across the United States, and specifically to young people. Overdose deaths continue to rise. They can be difficult to distinguish from suicide. Importantly, suicide rates among those with opioid use disorder is 87 per 100,000. If you remember, we were looking at the highest rates for male being 30 per 100,000, so extremely high rates of suicide risk related to opiate use. And suicide and opiate overdose have driven 3-year declines in US life expectancy. So two recent contributors that clinicians need to be aware of. Next slide. So I'd like to focus a little bit on athletes and suicide, and we need to think about athletes as a unique population as it relates to both their risk as well as protective factors. We know there are many protective factors that are inherent to athleticism, including exercising, taking care of one's body, eating well, sleeping well, being involved in community and team-related activities, are also positive effects on mental or all positive effects on mental health and decreased risk for suicide. But athletes also share the same risk factors as their peers, and there are other potential risk factors associated with athletes that clinicians need to be aware of. For example, there's increased physical and psychological demands, oftentimes perfectionism, unrealistic expectations and disappointments related to injuries, for example, that can be performance ending. Although there's been no specific association between sports-related concussions and suicide risk, there has been association between traumatic brain injury and risk for suicide in the general population. And when there's post-injury pain management that includes the use of opiates in young athletes, we need to be careful to ensure that that's not contributing to the potential of an opiate use disorder that could add risk for suicide. In addition, some athletes, both males and females, are at greater risk for body image disturbances, and the mental toughness that's required for competition in sports can also contribute to stigma associated with seeking care when it's appropriate. Next slide. So what do we do under circumstances, and when do we choose to screen young people who we believe are at suicide risk? And there are different recommendations for this. So the National Institute of Mental Health has developed a suicide risk screening pathway. You can see the algorithm in the figure on the right. And essentially what NIMH says is that all new patients, or those who've not been seen in a certain amount of time, or those with prior suicide risk, should be screened for suicide. Other organizations, including the U.S. Preventive Services Task Force and the American Academy of Pediatrics, have stated that there's not enough evidence to recommend universal screening for suicide in young people. However, when individuals pose risk, or the types of risk factors that were identified in the prior slides are present, or when a parent identifies risk in a youngster, then clinicians should always be considering the importance of suicide screening. Next slide. There are multiple tools for suicide screening, but the one I'd like to recommend is the ASQ, or the Ask Suicide Screening Questions, that is part of the NIMH toolkit. The reason I like it is, first of all, it's very simple. It consists of 4 questions with a follow-on question if any of the first 4 are positive. This is an assessment that has been studied in both primary care and specialty care settings, and it has shown very high sensitivity and specificity in identifying suicide risk, better than other screening instruments that we often use, like the PHQ-9 for depression. This is a suicide-specific screening. It also provides very simple language. And when it comes to screening for suicide, although mental health clinicians, psychiatrists, psychologists, social workers can be very comfortable with assessing suicide in young people, in patients that come into their clinics, for primary care and specialty care clinicians, it may be something that they're less familiar with. So this screening instrument provides very simple language to ask, and it encourages clear questions about suicide that can help guide decision-making for the clinician. Again, if any of the first 4 questions, like in the past few weeks, have you wished you were dead, are answered affirmatively, you ask a 5th question that intends to address the imminence of suicide risk. Are you having thoughts of killing yourself right now? Yes or no? Next slide. Depending upon the response to those questions, there is a brief suicide safety assessment that's recommended by NIMH. It's always important to praise a patient for describing their thoughts and willingness to describe the fact that they are having suicidal ideation or they're planning to do something to hurt themselves. But it's equally important to follow it up, whether it's done by you as a clinician in the primary or specialty care setting, whether it's done by a colleague in the clinic, or that the patient is referred for a mental health assessment. We need to assess the frequency of suicide thoughts, the plan, past self-harm, symptoms of depression, anxiety, irritability, and sleep, social support, and stressors. It's also important to always engage the family in assessing safety, especially if an individual is going to be returning home, and always assessing access to lethal means and restricting access to lethal means where appropriate. Next slide. As a result of that assessment, it could lead to any one of a number of additional steps and require the involvement of other available resources, including emergency psychiatric evaluation, an urgent or non-urgent mental health follow-up. And in circumstances where it's challenging to find that kind of assistance, dialing 911 or using the local emergency room or accessing the National Suicide Prevention Lifeline or the crisis text line is always something that's available both to patients, to families, and to clinicians. Next slide. This is a list of some resources for practitioners, specifically those who are working with athletes, some newer manuscripts and journal articles that have and books that have been published examining risk specifically in the population of athletes. There are also a number of important resources that are available through the NIMH as it relates to their suicide risk screening pathway that I would encourage clinicians to be aware of, to download, and have available to them in their clinics. Next slide. Thank you for your attention. Please feel free to access additional information at our center's website, www.cstsonline.org. Or for any questions related to this presentation, please feel free to email me at stephen.cozza@usuhs.edu. Thanks again.